Okay, let's unpack this. We're diving into something absolutely critical for your practice, this escalating challenge right at the intersection of diabetes, obesity, and liver health in India. Metabolic dysfunction is just soaring, and with it comes this rising tide of metabolic dysfunction-associated steatotic liver disease, MASLD. You might know its predecessor, NAFLD. But this isn't just semantics, is it? It's really a recognition that this liver condition is fundamentally tied to the metabolic issues you manage day in, day out.
It absolutely is. And that puts you, as endocrinologists and diabetologists, squarely on the front lines.
Yeah.
And that's precisely why this deep dive is so timely. We're digging into a recent expert consensus statement, pretty much fresh off the press, from leading Indian diabetologists. 30 experts, they came together, and their collective insights were published in Diabetes, Obesity, and Metabolism. It's a special issue article.
Right.
And it's really designed as a roadmap for, screening, diagnosis, management, all framed within the unique clinical realities you face in the Indian setting.
And the source itself sounds fantastic, open access. Always a plus for getting the information out there.
Our mission today isn't just to summarize it, though. We want to really pull out the absolute most important nuggets of knowledge, the actionable insights that you can actually take and apply in your clinic.
How does this consensus statement fundamentally guide practitioners, specifically in India?
MASLD is, quite literally, the hepatic manifestation of metabolic syndrome.
The liver showing the strain.
Exactly. It's the liver showing the effects of the same underlying issues, especially that key player. Insulin resistance that drive type 2 diabetes, obesity, dyslipidemia, hypertension, all the things you manage. The source really emphasizes this bidirectional relationship between K2DM and ASLD. They kind of feed each other, with insulin resistance being that shared core pathology. This document is really crafted to equip you with strategies to navigate this complex interplay.
And it officially embraces the recent nomenclature shift, too, moving from NAFLD to MASLD.
Yes, and that's more than just changing a name. It reflects a deeper scientific understanding. While the consensus document, it uses both terms contextually, acknowledging the transition period, it leans heavily towards MASLD. And this change really underscores the metabolic roots of the disease. It also aims to address the perceived stigma attached to the word fatty.
Opting for Steatotic instead.
Right, which just means containing or characterized by excessive fat. It's more technical, less loaded, perhaps.
Now, let's get right into the context this consensus lays out. It starts by looking at the sheer scale of the MSLD burden, both globally and crucially in India.
Setting the stage. Globally, the source points to figures, like in Table 1 and Figure 2, showing prevalence that varies quite a bit depending on the population studied, maybe 13% up to almost half the general population worldwide in some estimates.
Huge range.
But that number just skyrockets in individuals with T2DM. We're talking estimates between 45% and 70%.
Wow.
For instance, they cite Latin America with maybe 24% in the general population, but you look at obese or diabetic populations there, and it hits staggering 68%. Yeah, Asia Pacific, maybe around 30% generally, but 53% in diabetes populations. It's consistently high in these risk groups.
Those are already alarming numbers globally. But then you zoom in on India, looking at Table 2 in the source, and the picture gets, even more complex and frankly quite concerning.
It really does. The Indian data shows immense variation, which is actually an insight in itself. You see figures as low as 8.7% in a rural study, contrasting sharply with estimates like 73.6% in a group of newly diagnosed diabetes patients in North Bihar, or 56.4% in a Delhi population study.
That's enormous.
It is. And a meta-analysis they cite puts the average adult population prevalence in India around 38.6%. But then look at obese children, 63.4%.
Over 60% prevalence in obese children. That's absolutely chilling. It really hints at the future burden we're storing up.
It does. It's a major warning sign.
So why such a massive range in the Indian data specifically? What's driving that variability?
The consensus statement is pretty clear on this. They attribute it largely to differences in the diagnostic methods used across studies. Some rely on basic ultrasound, others might use different scoring systems or criteria.
Right.
And the clinical presentations themselves can vary. So this lack of uniformity in how MASLD is actually identified and diagnosed across India contributes to inaccurate prevalence data, makes it hard to get a consistent national picture.
So Statement 1 in the document basically calls for revisiting these numbers.
Exactly. Now that clearer diagnostic criteria are being adopted globally, the hope is India can adopt them too, leading to more reliable estimates.
And Statement 2 pulls no punches, calling MASLD a major public health concern in India.
Unequivocally. And the consensus highlights that underreporting is a huge issue. The true burden is likely underestimated, particularly, and this is key for you, in those high-risk groups you see every day.
People with diabetes, obesity, metabolic syndrome.
Exactly. These are vast segments of the Indian population now.
What specific factors does the source pinpoint as the key drivers for this escalating burden in the Indian population?
Well, it points directly to trends we're all witnessing in our clinics, right? The relentless increase in obesity and diabetes rates. But it was further highlighting specific dietary patterns common in India, notably excessive and regular intake of carbohydrate-rich diets. And you couple that with the dramatic rise in physical inactivity, and those are really the primary metabolic forces fueling MASD across the country.
It does feel significant that the government has recognized this, including MASLD, the National Program for Prevention and Control of Cancer, diabetes, cardiovascular diseases, and stroke, the MPCDCS, since 2021.
Absolutely. That's a crucial acknowledgement at the policy level. It has weight to the urgency. However, the consensus statement's remarks section really brings home the practical challenges on the ground in India that contribute to this underestimation and, frankly, hinder effective management.
What specifically?
They list limitations in infrastructure, the patchy availability of even basic ultrasonography, and especially more advanced tools like FibroScan once you get outside major urban centers.
Right. Access issues.
Big time. Plus, there's a significant lack of trained healthcare professionals who are really comfortable and equipped to diagnose and manage MASLD effectively.
And the fact that it's often asymptomatic, especially early on.
Precisely. They might come in for their diabetes checkup or their hypertension follow-up, completely unaware of this liver problem brewing silently.
Yeah.
So this asymptomatic nature, combined with the variable risk factors we see, and the current lack of sort of organized national screening programs specifically targeting MASLD, it means a huge number of cases are likely going undiagnosed.
So the consensus calls for
a strong, clear call for nationwide awareness campaigns and the urgent need for a population-wide screening program.
This really underscores why the diabetologist's role is so pivotal here. You're already seeing the highest risk patients anyway.
Exactly. Your patient panel is essentially the high-risk pool for MASLD. You're managing the very conditions, diabetes, prediabetes, obesity, dyslipidemia, hypertension, that are the diagnostic criteria for MASLD.
So integrating a quick screening step into routine visits could be hugely impactful.
Potentially one of the most impactful things that can be done at scale across India.
Okay, let's pivot slightly to the nomenclature change itself. It's relatively new, and this consensus really embraces MASLD. Can you walk us through that evolution as the source details it?
Sure. It's quite a journey, actually, and it highlights how our understanding of this disease has deepened over time. The source, especially Figure 1, traces it way back to 1836 with Thomas Addison describing fatty liver.
Okay.
Then, as histology became more common in the 20th century, terms like non-alcoholic fatty infiltration popped up in the 1980s. Then Ludwig, in 1980, coined NASH, non-alcoholic steatohepatitis, for the inflammatory form with liver cell injury.
Right, more severe form.
And then Schaffner and Thaler introduced NAFLD, non-alcoholic fatty liver disease, in 1987. That was the broader umbrella term covering the whole spectrum from simple fat accumulations all the way to NASH.
And NAFLD was the standard for decades. Then came MAFLD in 2020.
Yes, that was a big step change. An international consensus panel proposed Metabolic Dysfunction-Associated Fatty Liver Disease, MAFLD. The key shift there was moving away from the non-alcoholic exclusion criteria.
Why was that important?
The rationale was really to correctly classify liver disease primarily driven by metabolic dysfunction, even if the person consumed, say, modest amounts of alcohol. It fundamentally recognized the metabolic link as the defining feature, not just the absence of heavy drinking.
Which makes a lot more sense pathologically.
Exactly. And the latest change adopted by this consensus is MASLD in 2023. Led by major societies like ASSD and ESL, it became Metabolic Dysfunction-Associated Steatotic Liver Disease, MASLD. Similar to MAFLD, still emphasizing that metabolic dysfunction.
But changing fatty to steatotic.
Right. As the source mentions, one stated reason was to reduce perceived stigma associated with the word fatty. Steatotic sounds more clinical, perhaps.
Okay, so under this new MASLD umbrella, what are the key diagnostic criteria that you, as a diabetologist, really need to have?
So the diagnosis of MASLD requires three key things. First, you've got to exclude secondary causes of liver disease.
Like what?
Things like chronic viral hepatitis B or C, autoimmune liver diseases, drug-induced liver injury, genetic conditions like hemochromatosis or Wilson's disease. You need that standard workup to rule those out.
Okay, step 1, exclude others.
Step 2, you need evidence of hepatic steatosis, typically defined as liver fat affecting more than 5% of hepatocytes or detectable on imaging like ultrasound.
Yeah.
And third, and this is the critical part defining the metabolic dysfunction, the patient must have at least one of 5 specific cardiometabolic risk criteria.
The 5 criteria, let's hear them straight from the source.
Number 1, being overweight or obese.
And they use Asian Indian criteria here.
Yes, the source specifically references Asian Indian BMI criteria, over 23 kiloperimeters for overweight, over 25 kilometers for obesity, or central obesity using waist circumference over 90 centimeters in men, over 80 centimeters in women, as noted in Figure 5b.
Okay, so BMI or waist, what's number 2?
Number 2, having prediabetes or type 2 diabetes mellitus. This one criterion alone puts a massive number of your patients into the MASLD risk pool if steatosis is present.
Huge implications. Number 3.
Dyslipidemia, specifically high triglycerides 1.7 millimol or 150 milli-GDL or higher, or being on lipid-lowering treatment.
Okay, number 4.
Low HDL cholesterol, less than 1.0 millimol or 40 milli-GDL in men, or less than 1.3 millimol or 50 milli-GDL in women, or again being on treatment aimed at raising HDL.
And the 5th.
Hypertension, defined as blood pressure 130 or 85 millimeters or higher, or being on antihypertensive treatment.
If you find hepatic steatosis, say, on an incidental ultrasound in a patient who also has type 2 diabetes, even if their liver enzymes are totally normal, they meet the criteria for MASLD, provided you've reasonably ruled out other significant liver diseases.
Exactly. Or if they have steatosis plus obesity, or steatosis plus hypertension, or steatosis plus dyslipidemia, just one of those 5 metabolic criteria plus the steatosis and the exclusion of other causes clinches the MASLD diagnosis.
And that's the real power of this definition, isn't it? It explicitly links the liver condition to the metabolic problems you're already managing.
Precisely. It brings in practitioners like you, like diabetologists, acknowledging the shared pathology and the need for integrated care. It's not just a gastroenterology issue anymore.
That shift feels really important.
It absolutely does. It formalizes what many of us have recognized clinically for years, that the fatty liver isn't separate. It's part of the same metabolic storm as the high blood sugar, the high cholesterol, the insulin resistance.
Let's dive into the engine room then, the pathogenesis. The source talks about moving from the older 2-hit idea to a more complex multi-hit theory. What's the difference?
Yeah, the old 2-hit hypothesis was, well, a helpful starting point. First hit, fat accumulates in the liver, steatosis. Second hit, something else happens, like inflammation or oxidative stress leading to damage, NASH and fibrosis.
Seemed logical.
It did, but it was probably too simplistic, too linear. The multi-hit theory, which they illustrate nicely in Figure 3, acknowledges that it's not just 2 sequential events. It's a complex interplay of multiple insults, multiple hits, happening perhaps simultaneously or interacting over time.
So what's the core pathological process at the heart of this multi-hit model then?
At its absolute core, it's about the dysregulation of fatty acid metabolism within the liver. The liver basically becomes overwhelmed with lipids, disrupting its normal function.
What are they?
The source lists several key players. There's the ever-present insulin resistance, of course, specific dietary influences like high fructose, high saturated fat intake. Chronic hyperglycemia itself plays a role. Dyslipidemia, naturally. Then there are genetic predispositions that make some individuals more susceptible than others. And even epigenetic modifications, changes in gene expression without changing the DNA sequence itself.
And these factors don't act alone.
They interact in complex ways, creating this sort of permissive environment for MASLD to first develop, and then, unfortunately, to progress to more severe stages.
Let's pull on that thread of insulin resistance, since it's so central to diabetes and your expertise. How does it specifically drive fat accumulation in the liver, according to the source?
This is really the linchpin for so many patients you see. Adipose tissue insulin resistance is particularly critical.
Resistance in the fat cells themselves.
Exactly. When adipocytes become resistant to insulin signals, insulin can no longer effectively suppress lipolysis, the breakdown of stored fat. This leads to an unchecked release of vast amounts of free fatty acids, FFAs, into the bloodstream. These FFAs then flood the liver. The liver dutifully takes them up.
Cool.
Now, this increased supply of FFAs from outside, combined with increased hepatic de novo lipogenesis, DNL.
which is the liver making new fat itself.
The liver synthesizing its own new fatty acids, particularly from excess carbohydrates, especially fructose. This combination leads to a massive buildup of triglycerides within the liver cells, the hepatocytes.
More fat coming in from dysfunctional fat tissue, and the liver making more fat internally via DNL.
And the source specifically points to enzymes like acetyl-CoA carboxylase, ACC, and fatty acid synthase, FAS, as key rate-limiting steps in this DNL pathway. They get upregulated in the setting of insulin resistance and high substrate availability from, say, excess carbs, further fueling that fat accumulation.
And this overload of lipids creates what you called a lipotoxic environment.
Yes. This excess, misdirected fat is literally toxic to the hepatocytes. It leads to stress in crucial cellular organelles like the endoplasmic reticulum, that's ER stress, and the mitochondria, causing mitochondrial dysfunction. These stressed organelles start releasing reactive oxygen species, ROS, causing oxidative stress. This cellular stress and damage then triggers inflammatory responses. Immune cells get recruited to the liver, you start seeing DNA damage. Plus, insulin resistance itself promotes a pro-inflammatory state throughout the body, including the liver, via cytokine secretion. That's the engine. It drives the progression from simple steatosis, which might be relatively benign, to the more damaging steatohepatitis, MASH, with its inflammation and cell injury, and ultimately towards fibrosis, cirrhosis, and even liver cancer.
This is the same picture there.
Not entirely the same, but there's definitely overlap. While insulin deficiency is the primary issue in type 1, insulin resistance can still develop, especially with suboptimal metabolic control or increasing body weight over time. The source suggests mechanisms in T1DM might involve things like poor lipolysis, leading to enhanced triglyceride synthesis, maybe glucose-induced lipogenesis happening even without hyperinsulinemia, perhaps via transcription factors like THR-BP and SREBP1C, and potentially increased glucose uptake by the liver if GLU2 transporters are upregulated. So the drivers of fat accumulation can differ somewhat from the classic T2DM picture.
Are there other endocrine conditions besides diabetes that are linked in the consensus?
Yes, absolutely. The consensus specifically notes associations with suboptimal thyroid function, growth hormone deficiency, and hypopituitarism. These are all conditions that can significantly influence metabolism and predispose individuals to hepatic fat accumulation.
So treating the underlying endocrinopathy is key.
Essential. They even mention how medications like thyromimetics, by activating the hepatic thyroid hormone receptor beta, THRO, can improve liver fat clearance by boosting lipid metabolism enzymes. It just underscores how interconnected the whole endocrine system is with liver health. Statement 12 later really reinforces the need to screen patients with these long-term endocrinopathies for MASLD.
And what about environmental factors like air pollution? That feels like a newer angle.
It is, and it's particularly relevant for India given the significant air quality challenges in many areas. The source references studies, including some from India, showing pretty strong associations between exposure to particulate matter, PM2.5, and an increased risk of type 2 diabetes, dyslipidemia, and hypertension.
The core metabolic risk factors for MASLD itself.
Exactly. So while the link between pollution and MASLD isn't yet as direct as, say, diet or insulin resistance, it highlights how external environmental factors can potentially exacerbate the metabolic drivers of liver disease. The consensus does note the need for more direct studies specifically looking at air pollution and MASLD development in India.
Given that MASLD is often silent, who specifically should we, as diabetologists seeing patients with all these metabolic issues, be actively screening or keeping a really close eye on? This seems crucial, touching on statements 3, 4, and 5.
This is probably one of the most critical, actionable sections for your day-to-day practice. First off, Statement 3 makes it crystal clear. MASLD isn't just confined to those who are visibly obese.
Right, the lean MSLD concept.
It definitely occurs in normal weight individuals too, although less commonly. So you can't just screen based on BMI alone. You might miss people. Host, speaker. Absolutely. We all see patients with a normal BMI but significant metabolic dysregulation, high triglycerides, low HDL, maybe central obesity. Precisely.
Yeah.
Then Statement 4, which is nicely summarized in Figure 4 in Table 3, gives key criteria for individuals who should be actively followed up for evaluating disease progression. These are the folks at high risk who need attention beyond just initial identification.
Okay, who falls into this category?
Several groups. First, anyone found to have liver steatosis on imaging, defined as greater than 5% liver fat. Second, individuals with unexplained elevated liver enzymes. The consensus uses a practical threshold of plasma aminotransferase levels greater than 30 UL.
A simple LTAS check.
Yes, above 30 warrants a closer look. Third, patients with a family history of a first-degree relative diagnosed with liver cirrhosis suggest potential genetic or shared environmental risks. Fourth, overweight or obese individuals, again using those Asian Indian BMI criteria, 23 kilometer form. This applies whether they have other metabolic dysregulation or not, although they very often do.
That covers a huge proportion of patients in India.
And fifth, critically, all individuals with type 2 diabetes or prediabetes. This is a blanket recommendation.
According to this consensus, every single patient with T2DM or prediabetes walking into our clinic is automatically considered in this high-risk category, needing evaluation or follow-up for MASLD progression if steatosis is found.
That's precisely the recommendation. Given that incredibly tight bidirectional link with insulin resistance, the mere presence of diabetes or prediabetes is considered a major risk factor, warranting careful consideration and follow-up for MASLD progression if steatosis is present. It puts a significant responsibility, but also a significant opportunity, squarely on diabetologists.
And Statement 5 in Table 3 lists some additional conditions where screening should be considered as well.
Yes, extending that high-risk pool even further to conditions often seen in your practice or clearly associated with metabolic issues. Things like polycystic ovarian syndrome, PCOS,
Very common.
obstructive sleep apnea, OSA, chronic kidney disease, CKD, even a history of cholecystectomy gallbladder removal, which can sometimes be a marker of underlying metabolic problems, and also HIV infection, where metabolic complications are increasingly recognized.
This really hammers home the point that the diabetologist is ideally positioned for this kind of opportunistic screening during routine appointments.
Absolutely. BMI, waist circumference, blood pressure, lipids, glucose control. Adding a conscious consideration for liver health, perhaps starting with simple liver enzymes or a non-invasive score like FeB4, is a very natural extension of the comprehensive metabolic care you already provide.
Okay, so once we've identified someone at risk, or maybe they have elevated enzymes or steatosis on ultrasound, how do we move towards a more definitive diagnosis and, crucially, stage the disease? Specifically, assessing for fibrosis seems key.
Right, because fibrosis stage is the strongest predictor of long-term outcomes. First, as we mentioned earlier, the source emphasizes that MASLD is fundamentally a diagnosis of exclusion.
Rule out the other stuff first.
Viral hepatitis serology, Hep B, Hep C, autoimmune markers like ANA, SMA, iron studies, plasma iron ferritin transferrin saturation for hemochromatosis, ceruloplasmin for Wilson's disease, alpha-1 antitrypsin levels, etc. This initial workup is essential before you confidently label something as MASLD.
Once other causes are excluded, how do we assess the extent of the problem non-invasively?
Statement 6 underscores the need to use multiple modalities because honestly, no single non-invasive tool is perfect. Simple biochemical tests like serum liver enzymes, AST, ALT, are a starting point, but normal enzymes do not rule out MASLD or even advanced fibrosis, a very common and dangerous one. Many patients, a significant proportion actually, with advanced fibrosis or even cirrhosis can have persistently normal ALT and AST levels. So you can't rely on enzymes alone to rule out significant disease.
What about imaging just for detecting the steatosis itself?
Ultrasonography is, of course, widely available in India and often the first tool used if steatosis is suspected clinically or based on enzymes. It's got pretty good sensitivity and specificity for detecting the presence of moderate to severe steatosis. But its ability to accurately quantify the amount of fat is limited. And crucially, ultrasound is very poor at assessing fibrosis. It just doesn't see scarring well. Plus, its sensitivity for detecting even steatosis can be lower in patients with significant obesity due to technical limitations.
So, for assessing fibrosis, which we agree is the key prognostic factor, we really need specific non-invasive tools. The consensus highlights a few key scoring systems in Table 5.
These are absolutely vital for risk stratification right there in your clinic. The Fibrosis 4 Index, or FIB4 score, is specifically highlighted in Statement 6 as a really valuable prognostic tool for both screening and risk stratification in MASLD.
And it uses simple, readily available data.
Exactly. That's its strength. It uses just 4 variables: patient's age, AST level, ALT level, and platelet count. Data you likely already have or can easily get.
And the cutoffs for risk stratification are pretty well defined.
Yes, the source provides clear, widely accepted cutoffs. FIB4 score less than 1.3 is generally considered low risk for advanced fibrosis, meaning stages F3 or F4 cirrhosis. The likelihood of significant scarring is low in this group.
Okay, so 1.3 is reassuring.
Scores between 1.3 and 2.67 fall into the indeterminate risk zone. These patients might need further evaluation, and scores greater than 2.67 indicate a high risk of advanced fibrosis. These individuals definitely warrant further investigation, often with more advanced techniques or referral.
Calculating FE4 seems like a really good first-line step for ruling out significant fibrosis in many cases.
Absolutely. It's an excellent, validated, inexpensive tool for ruling out advanced disease in a large proportion of patients and helping you identify who needs that next level of workup. The consensus also mentions other scores like the NAFLD fibrosis score, NFS, which is a bit more complex, including BMI, presence of diabetes IFG, a STALT ratio, platelets, and albumin, and the AST to platelet ratio index, APRI, which is simpler again. All these scores help predict liver-related outcomes and mortality, and they're crucial for stratifying patients towards more specialized assessment if their score indicates intermediate or high risk.
Beyond these calculated scores, imaging-based elastography techniques seem key for directly assessing liver stiffness, which correlates with fibrosis.
Yes, elastography is a major advance. These techniques estimate liver stiffness by measuring how fast mechanically induced waves travel through the liver tissue. Stiffer tissue, like scarred tissue, transmits waves faster.
And the consensus specifically mentions VCTE or FibroScan in the Indian context.
Statement 7 is particularly important here. It names vibration-controlled transient elastography, VCTE, which is performed using devices like FibroScan as the best validated imaging modality for non-invasive diagnosis and staging of fibrosis in Indian clinical practice.
How does FibroScan give you information on both the fat and the stiffness?
It's quite clever. The FibroScan probe is placed on the skin over the liver. It generates a low-frequency mechanical shear wave, and ultrasound sensors measure how fast that wave travels through the liver parenchyma. This speed directly correlates with liver stiffness, which is reported in kilopascals, kPa. The same technology also uses the attenuation or weakening of the ultrasound signal as it passes through the liver. Fatty tissue attenuates ultrasound differently than non-fatty tissue. This is measured as the controlled attenuation parameter, or CAP, reported in dB. So a single FibroScan measurement gives you both an estimate of fibrosis, LSM, and steatosis, CAP.
Very efficient.
It is. And the source notes that VCTE results, both LSM and CKP, correlate well with liver biopsy findings and, importantly, can predict future liver-related events like decompensation or cancer. They also mention different probes, MSXL, are available to optimize measurements based on patient body habitus.
Acoustic radiation force impulse, ARFI imaging, is also mentioned as an emerging tool. Seems like another ultrasound-based method.
Yes, Statement 7 includes ARFI. It's another non-invasive ultrasound-based technique, often integrated directly into standard diagnostic ultrasound machines, which might improve accessibility. It generates shear waves using focused acoustic pulses from the transducer itself and measures tissue elasticity either at specific points, point shear wave elastography, or over a 2D area, 2D SWB.
And its performance.
It's reported to have good sensitivity and specificity for detecting liver fibrosis, and also correlates reasonably well with histopathology. It's definitely becoming another valuable option in the non-invasive toolkit, potentially more accessible if it's part of an existing ultrasound setup.
So, lots of non-invasive options, according to this consensus.
Statement 8 indicates liver biopsy is typically reserved now for pretty specific situations. One is individuals undergoing bariatric surgery, where a histological assessment is often part of the standard preoperative evaluation. The other main indication is in patients suspected of having a high risk for MASLD progression, especially when the clinical picture and the non-invasive tests, like FE4 and elastography, are maybe conflicting, or they don't fully explain the severity of the liver enzyme elevation or other clinical signs, or sometimes to rule out coexisting liver diseases if suspicion remains high.
So it's not for everyone anymore.
Definitely not. While it's still the ultimate gold standard for providing detailed information grading the degree of inflammation and ballooning, staging fibrosis with precision, it's invasive, carries small risks, is expensive, and prone to sampling error. So it's reserved for when non-invasive methods aren't sufficient to guide management.
Okay, so piecing that together, the practical approach for a diabetologist who identifies a high-risk patient might often look like this. First, rule out other liver diseases with basic blood work. Then, calculate FE4. If FE4 is low, 1.3, that's reassuring, maybe just routine follow-up needed.
Correct.
If FE4 is indeterminate, 1.3 down 2.67, or high, 2.67, then the next step would likely be VCT FibroScan or perhaps ARFI for a more definitive, non-invasive assessment of both fibrosis, LSM, and steatosis, CAP.
Exactly. That kind of sequential approach helps risk stratify patients effectively using tools that are hopefully becoming increasingly available at least in many centers. And based on those results, you decide on the intensity of follow-up or potential referral to a hepatologist or gastroenterologist.
Right. Now let's get to the core of management. The consensus is absolutely unequivocal here. Lifestyle modification is the foundation.
Statement: lifestyle modification is the first and most important step. Before you even think about medications specifically for the liver, you have to address diet, exercise, and weight management. And this applies across the board, whether the patient has simple steatosis or more advanced MESH.
And the source provides some really clear quantitative weight loss targets that are linked to actual histological benefits. These seem like powerful numbers to share with patients.
They are incredibly motivating. Achieving a weight loss of 5% or more of total body weight is associated with a significant reduction in liver steatosis, the fat itself.
Okay, 5% for fat reduction.
Losing between 7% and 10% of body weight can lead to actual improvement in steatohepatitis, meaning reduction in inflammation and hepatocyte injury or ballooning.
So 7–10% for tackling the inflammation.
Right. And critically, achieving a sustained weight loss of 10% or more has been linked to improvement, even regression, in liver fibrosis itself.
Wow, actually reversing scarring with weight loss.
In some cases, yes. It highlights the profound impact that significant metabolic improvement through weight loss can have on liver health, even on established scarring. The source also makes the point that diet and exercise can reduce liver fat even in those normal weight individuals with MASLD, showing that the metabolic benefits aren't solely mediated by hitting a certain BMI target, but by fundamentally improving insulin sensitivity and fat metabolism pathways.
Let's delve into the dietary recommendations, especially looking at the specific Indian context the consensus discusses. It's not just eat healthy, is it?
The general principle is adopting a hypocaloric diet if weight loss is needed, generally lower in fat, especially saturated and trans fats, and with a low glycemic index. However, the document provides valuable insight into typical Indian dietary patterns,
Which are
often very high in cereals and whole grains, which can make up 50–70% of total energy intake, and relatively low in protein, fruits, and vegetables compared to recommendations. They even reference findings like the Eat Lancet report suggesting diets across many Indian states are often unhealthy, contributing significantly to the overall metabolic burden.
So what are the specific Indian recommendations coming from sources like ICMR, NNA, or the INDIAB study that the consensus highlights? How should we advise patients?
They strongly recommend minimizing ultra-processed foods and foods high in fat, sugar, and salt. That's standard healthy eating advice globally, but particularly critical given their increasing prevalence in Indian diets. The ICMR INDIAB study data is really key here.
What did that show?
It showed very high carbohydrate intake, often 60–70% of total energy, alongside low protein and fiber consumption, correlating with the high rates of diabetes, prediabetes, abdominal obesity, and hypertension. So based on this, the consensus recommends a practical shift. Substitute about 10–15% of refined carbohydrates, high glycemic index foods like white rice, white bread, sugary drinks, with protein sources, preferably plant-based proteins like lentils, legumes, beans, and also incorporating more healthy fats, monounsaturated fats found in mustard oil, groundnut oil, nuts, and polyunsaturated fats like omega-3s.
More protein, more healthy fats tailored to typical Indian eating habits.
Exactly. It's about improving the quality of the diet within the cultural context. They also mention beneficial dietary patterns like the Mediterranean diet and well-planned vegetarian diets, which are known for both hepatic and cardiovascular benefits. Diets high in red and processed meats, rich in saturated fats, and simple sugars, especially fructose from sweetened beverages, are strongly linked to development and progression and should be minimized.
Makes sense. And exercise.
Regular physical activity is presented as absolutely non-negotiable. It works on multiple levels. It improves body composition, crucially enhances insulin sensitivity in both the liver and the adipose tissue, attacking that core problem, and has benefits for reducing liver fat even independent of significant weight loss.
What kind of exercise?
Combining both aerobic exercise things like brisk walking, jogging, cycling, swimming, and resistance training using weights or resistance bands is generally recommended. This combination seems best for reducing steatosis and improving overall cardiometabolic outcomes.
And the context in India regarding activity levels.
Yeah, the source includes quite concerning WHO statistics showing physical inactivity nearly doubled in India between 2000 and 2022, from about 22% to nearly 49%. That's a stark reminder of the scale of the challenge we face in promoting activity.
That statistic alone is a huge call to action for all of us counseling patients.
It absolutely is. The document also briefly touches on nutraceuticals, but generally notes the lack of substantial high-quality evidence to support their routine use for treating MSLD specifically. Interestingly, though, it does note that coffee consumption, maybe 3 or more cups per day, has shown some potential beneficial effects in observational studies.
So lifestyle, diet, exercise, weight loss is clearly the bedrock. But what about pharmacological interventions? The consensus notes this is a rapidly evolving landscape.
It is, and it's where things get quite complex and exciting right now. Statement 10 starts by addressing drug therapy. It first lists several agents that have been used historically, or are sometimes still used, but lack robust, high-quality evidence supporting their continued use specifically for treating MSLD itself.
Which drugs fall into that category?
Things like vitamin E, although the consensus notes some guidelines recommend it for specific subsets, like non-diabetic patients with biopsy-proven MASH, but not broadly for MASLD. Others include ursodeoxycholic acid, UDCA, omega-3 polyunsaturated fatty acids, PUFAs, silymarin, milk thistle, and the weight loss drug Orlistat. Basically, these are not broadly recommended as primary MSLD treatments based on the current evidence for histological improvement.
What about drugs with some evidence, maybe not definitive, but showing potential?
Obeticholic acid, OCA, which is an FXR agonist, is mentioned. It does have some evidence suggesting it can modulate bile acid synthesis, potentially improve insulin sensitivity, and reduce hepatic steatosis. However, its use is often limited by side effects like pruritus, itching, and concerns about effects on lipids requiring careful patient selection and titration.
The anti-hyperglycemic agents. Statement 11.2 discusses their role specifically in patients who have both T2DM and MASLD.
Right. This is where clinical practice meets emerging evidence and guideline nuances. The consensus notes that drugs like metformin, pioglitazone, SGLT2 inhibitors, and GLP-1 receptor agonists, GLP-1RAs, are very commonly used, essentially off-label for the liver indication in patients with T2DM and MASLD.
And they are considered preferred agents for managing the hyperglycemia in this specific population.
They are preferred for managing the blood sugar in these patients because they might confer additional hepatic benefits beyond just glucose lowering.
But, and this seems like an important distinction, they aren't primarily approved or recommended as MSLD treatments themselves.
Not based on current evidence for direct histological improvement, according to this consensus. Statement 11.2 explicitly states that none of the existing anti-hyperglycemic agents have proven direct primary hepatic benefits, specifically for treating MASLD or resolving MAS histology in large definitive trials. Their benefit to the liver is thought to be largely secondary to their positive effects on the underlying metabolic drivers, improving insulin sensitivity, promoting weight loss, better glucose control.
So you choose them for diabetes management knowing they might help the liver too, but not as a primary liver therapy.
Exactly. You're treating the diabetes optimally and choosing agents that align well with the overall metabolic profile, including the liver involvement. The consensus also specifically mentions that insulin therapy is generally recommended only in patients with decompensated cirrhosis, where other agents might be contraindicated or insufficient.
So where are the agents that do seem to have more direct hepatic benefits emerging? This is the really hot area.
This is where the field is most exciting. The consensus highlights 2 key agents specifically. First, resmetirom. This is mentioned in Statement 10. It's a novel drug, a selective thyroid hormone receptor beta, THR-BARC agonist. It preferentially targets the THR-beta receptor, which is highly expressed in the liver. Activating it promotes processes like lipid breakdown, lipophagy, and mitochondrial fatty acid oxidation, directly helping to reduce liver fat content. It recently received FDA approval in the U.S. specifically for treating MAHH with moderate to advanced fibrosis, stages F2, F3. That was a major milestone.
Huge news globally. But what's the situation with resmetirom in India?
This is where Statement 11.1 provides the crucial local context. Resmetirom is currently unavailable in India, and the consensus explicitly notes that its likely substantial economic burden will be a major factor limiting its accessibility for the vast majority of Indian patients, even if it does eventually become available. This is where seraglitazar comes into the picture, also mentioned in Statement 10. Seraglitazar is different. It's a dual PPAR alpha and PPAR gamma agonist.
Okay, and its status in India.
The consensus confirms its approval by the DCGI, Drug Controller General of India, specifically for treating MASLD and non-cirrhotic MASH in India. This is significant. They briefly mention phase 3 trial data showing improvement in liver histology, particularly the NAS score, NAFLD activity score, without worsening of fibrosis compared to placebo.
So an approved option in India targeting the liver condition.
Yes. However, the source also adds important caveats. Seraglitazar is currently only available in India, and it requires more long-term data, particularly regarding its renal and cardiovascular safety profile. So while approved and available, ongoing assessment is needed.
That's a really significant point of difference for practice in India compared to many other parts of the world. What about the GLP-1 RAs like semaglutide? Are they considered purely for glucose control, or is there more evidence emerging for liver benefits?
The consensus includes injectable semaglutide, Statement 10, among the promising agents, going a bit beyond just glucose control. There's definitely accumulating evidence showing it has some ability to prevent MASLD progression and potentially even induce regression of fibrosis. This is likely mediated significantly through the substantial weight loss it causes, but also perhaps through direct effects on inflammation and insulin sensitivity. Yes, the source cites trial results where a higher percentage of patients on semaglutide, specifically 37% on the 2.4 milligram dose, which is the weight loss dose, showed improvement in liver fibrosis stage without worsening of steatohepatitis compared to placebo, which was 22.5%. So a positive signal for fibrosis improvement.
But again, the practicalities.
Exactly. Statement 11.1 brings it back to earth, reiterating that cost considerations for GLP-1 arrays will undoubtedly be a major factor for widespread MASLD treatment in the Indian setting, beyond just their use for diabetes or obesity. Specific pharmacoeconomic data for MASLD indication is still lacking. The consensus makes a very strong point here. Cardiovascular disease, CVD, is the leading cause of morbidity and mortality in patients with MASLD. They are far more likely to die from a heart attack or stroke than from liver failure itself, especially in earlier stages.
So managing CV risk is non-negotiable.
Non-negotiable. Therefore, the consensus states that statins should be recommended in essentially all MASLD patients who meet standard criteria for primary or secondary CV prevention, just as you would routinely recommend them in patients with diabetes or metabolic syndrome. Concerns about statin hepatotoxicity are largely historical and overstated for most patients. Statins might even offer some additional hepatic benefits themselves, though their primary indication here is clearly CV risk reduction. So, don't withhold statins due to MASLD diagnosis alone if they are indicated for CV protection.
Bariatric surgery is also noted briefly as an option.
Given its profound and sustained impact on weight loss and metabolic parameters, it often leads to significant improvement or resolution of MASLD, including fibrosis regression in many cases.
Statement 11 contained a note that seemed to highlight a practical gap, specifically in the Indian context regarding follow-up.
It points out that the optimal frequency of follow-up assessments for patients on management, using tools like FibroScan or calculating EV-FEW scores to track disease progression or treatment response, is actually not well defined specifically within the Indian healthcare setting. This suggests a need for more research and potentially standardized protocols tailored to local resources and patient flow patterns.
A clear practice gap to address.
And Statement 11.2 also adds a nuance about when to consider drugs. Pharmacological options are primarily considered when individuals do not respond adequately to lifestyle interventions, but the decision can also be individualized based on the patient's overall risk profile and specific needs right from the start, especially if they have advanced disease or high-risk features.
Okay, let's peer into the future now. The consensus document touches on several quite exciting emerging concepts. Where's the field heading?
This section really gives a glimpse into the next wave of understanding and management. Statement 12 reinforces that link between long-term endocrinopathies beyond just diabetes, like growth hormone deficiency, hypothyroidism, hypopituitarism, and MASLD risk. It stresses that effectively treating the underlying endocrine disorder is essential to help mitigate the associated liver risks.
Makes sense. Statement 13 mentions HIV, smoking, and tobacco.
It notes their association with MASLD development and progression in some studies, but also prudently states that more evidence is needed to really solidify these links compared to the very strong metabolic drivers like obesity and diabetes.
Statement 14 seemed particularly interesting, emphasizing a focus on early diagnosis at a population level using the simplest possible tools. Given the infrastructure challenges we discussed in India, this feels highly relevant.
It's a very pragmatic and necessary approach. The source details some emerging screening tools and scores listed in Table 7 that really fit this simple tools philosophy. For instance, they mentioned the lipid accumulation product, or LAP.
How was that calculated?
Incredibly simply, just waist circumference multiplied by triglyceride level. It's proposed as a potential tool for early detection of steatosis risk.
Wow, using data points you collect routinely anyway.
Another one mentioned is the Hepatic Steatosis Index, HSI. This uses ALT, AST, BMI, diabetes status, and sex. It provides specific cutoffs that can help rule in 36 the likelihood of steatosis with reasonable accuracy, again using commonly available data. Yes, that uses HDL, triglycerides, HbA1c, white blood cell count, and hypertension status. Again, it offers cutoffs to help identify individuals with a low likelihood, 0.24, or high likelihood, 0.44, of having MASLD, MASLD, serving as another potential first-line screening tool. The appeal of these is their simplicity and reliance on routine data.
Are there emerging biomarkers beyond the standard liver enzymes being explored?
Yes, Table 8 lists a couple of promising ones that aim to reflect different aspects of the disease process non-invasively. One is cytokeratin 18 fragments. CK18. CK18 is released when liver cells undergo apoptosis, programmed cell death, which is a feature of NASH. Elevated levels, perhaps above 130.5 IUL is suggested, might indicate NASH rather than just simple steatosis. Another mention is procollagen C3, specifically its N-terminal peptide PROC3. Reflects active fibrogenesis, the process of scar tissue formation. Levels above a certain threshold, like 15.5 ng/ml suggested in the table, might indicate the presence of more advanced fibrosis. These could eventually provide non-invasive ways to assess both the inflammatory activity and the fibrosis severity.
Artificial intelligence and machine learning are also entering the picture for diagnosis and prognosis, aren't they?
Definitely. This is a rapidly advancing frontier. The consensus discusses the significant potential of AI and machine learning algorithms for developing more precise, non-invasive methods for measuring fibrosis, potentially refining disease classifications, improving prognostication models, and maybe even guiding personalized therapies down the line.
Are there examples of specific models?
Yes, it mentions that some machine learning models, like XGBoost and random forest algorithms trained on large data sets, are showing really impressive accuracy, with AUCs reported around 0.90 to 0.95 in identifying high-risk individuals. This potentially outperforms traditional simple biomarkers like FE4 or APRI, whose AUCs for predicting advanced fibrosis are often closer to the 0.7 error range. AI might help us get much better at non-invasive risk stratification.
The idea of a multi-omics approach mentioned in Statement 15 sounds powerful, though perhaps complex. What does that entail?
It's about integrating data from different biological layers simultaneously. Think genetics, genomics, proteins, proteomics, metabolites, metabolomics, maybe even the gut microbiome, microbiomics, to get a much more holistic, systems-level view of the disease in an individual patient. The source suggests that using a non-invasive multi-omics approach could significantly improve how we classify MASLD subtypes, stage the disease more accurately, and predict future outcomes.
And genetics is obviously a key piece of that.
The consensus specifically names several common genetic variants that are now well established as influencing SLD risk and progression. These include PNPA3, specifically the I148M variant, TM6SF2, GCKR, and MBOAT7. These genes are directly involved in how liver cells handle fats. They affect critical processes like how new fats are synthesized, DNL substrate delivery, how fats are stored in lipid droplets within the cell, how efficiently fats are burned for energy in mitochondria, how fatty acids are compartmentalized, and how lipids are packaged and secreted from the liver as VLDL particles. Knowing a patient's genotype for these common variants could significantly refine their individual risk profile.
So combining genetics with imaging or biomarkers could lead to more personalized management.
That's the hope, yes. Integrating genetic susceptibility information with clinical and imaging data could lead to much better risk stratification and perhaps more tailored prevention or treatment strategies in the future.
Other emerging concepts mentioned briefly include sarcopenia, lipidomics, and the gut microbiome.
Sarcopenia, the age-related or disease-related loss of muscle mass and function, is increasingly recognized as being common alongside MASLD, particularly in more advanced liver disease or in the context of sarcopenic obesity, the combination of obesity and low muscle mass. The source notes research gaps here, especially in South Asia, referencing the SWAG-Sarco consensus, despite sarcopenia likely being prevalent.
And lipidomics and metabolomics.
These omics technologies are revealing distinct patterns or signatures of lipids and small molecule metabolites in the blood or tissue that seem to track with mass biomarkers.
And the gut microbiome seems increasingly important.
Recent advances are revealing distinct microbial signatures in the gut associated with MASLD and NASH, particularly in patients who also have T2DM. The disruption of the normal gut barrier and the resulting changes in the gut-liver axis seem to play a key role in driving liver inflammation and fibrosis. This represents a really promising area for developing future therapies, perhaps targeting the microbiome itself.
Finally, Statement 16 offers a glimpse into the sheer breadth of the drug development pipeline for MASLD.
It really highlights the explosion of research activity. Drugs currently in clinical trials are targeting numerous different points in that complex multi-hit pathogenesis like we discussed earlier.
Like what kinds of targets?
Inhibiting de novo lipogenesis using ACC inhibitors or SCD1 inhibitors, modulating bile acid signaling and transport, reducing lipotoxicity and oxidative stress using compounds like various PPAR agonists or FGF agonists, FGF19, FGF21, directly tackling inflammation with inhibitors of key inflammatory mediators like AOC3, CCR25 chemokine receptors, or toll-like receptor 4, TLR4, preventing liver cell death pathways like apoptosis using caspase inhibitors or ASK1 inhibitors, or ferroptosis, and even trying to directly block or reverse fibrogenesis pathways using things like cyclophilin inhibitors.
And even exploration of exosome-based therapies.
Yes, the cutting edge. Using exosomes, tiny vesicles naturally released by cells potentially as a way to deliver therapeutic molecules specifically to the liver or to modulate inflammation. It truly shows the breadth of therapeutic angles being explored to tackle this complex disease.
Let's try and pull together the main key takeaways from the entire document for everyone listening.
We started with the undeniable, significant, and still escalating burden of MASLD right here in India. Driven by that perfect storm of rising diabetes, obesity, specific unhealthy dietary patterns, and increasing physical inactivity, underscoring its status as a major public health concern demanding attention.
We clarify the important shift to the MASLD nomenclature, which better recognizes its fundamental metabolic roots and aims to reduce stigma. And crucially, we detail the new diagnostic criteria that explicitly link MASLD to the very metabolic syndrome features you manage daily in your practice.
We explored the complex pathogenesis, moving beyond those older models to really understand how insulin resistance, diet, genetics, inflammation, and other factors all converge, cause leptotoxicity, drive inflammation, metabolic, and ultimately lead to fibrosis in the liver.
Critically for your day-to-day practice, we identify the specific high-risk populations that require active screening and follow-up. Most notably, that includes every patient with type 2 diabetes or prediabetes, plus others with known steatosis on imaging, unexplained elevated liver enzymes using that 30 UL threshold, a family history of cirrhosis, overweight obesity using those important Asian Indian criteria, and associated conditions like PCOS, OSA, CKD, post-cholecystectomy, and HIV.
We discussed the practical diagnostic approach, emphasizing the need to first exclude other chronic liver diseases and then using multiple non-invasive tools. Simple calculated scores like FE4 are vital for initial risk stratification to rule out advanced disease, and VCTE, or FibroScan, is highlighted as the best validated non-invasive imaging tool for actually staging fibrosis and steatosis severity within the Indian context.
We reinforce time and again that lifestyle modification focusing on diet and exercise leading to weight loss remains the absolute cornerstone of management. We discussed those specific motivating quantitative weight loss targets, 5%, 7-10%, all 10%, linked to histological improvement, and talked about practical dietary shifts tailored to the Indian context, reducing refined carbs, increasing protein and healthy fats.
On the pharmacological front, we navigated the evolving landscape. While traditional anti-hyperglycemic agents like metformin, pioglitazone, SGLT2Is, and GLP-1RAs are preferred for metabolic control in MASLD patients with T2DM due to potential secondary liver benefits, they currently don't have proven direct histological efficacy specifically for MASLD itself.
But promising agents with more direct benefits are emerging.
Exactly. We highlighted seraglutazar, which is uniquely approved and available in India for MASLD, and resmetirom, the THR beta agonist, recently approved in the US but currently unavailable and likely very costly in India. Plus, GLP-1RAs like semaglutide showing potential particularly for fibrosis improvement, though cost remains a barrier for broad MASLD use. And crucially, we emphasize that managing cardiovascular risk aggressively with statins is paramount in absolutely everyone with MASLD.
And finally, we touched upon that exciting frontier of emerging concepts, the strengthening link to other endocrinopathies, the development of simple scoring tools like LAP, HSI, and NRS for potential early population-level detection, promising novel biomarkers like CK18 and PROE3, the huge potential of AI and machine learning, the power of multi-omics and genetics for personalization, and the sheer breadth of new drugs targeting specific pathways currently in the development pipeline.
This consensus statement from leading Indian diabetologists really stands out. It's a valuable practical guide specifically crafted for practitioners like you working on the front lines here in India. It's clearly designed to elevate awareness and drive more timely, effective management strategies, all within the unique clinical realities and public health context of India. It also implicitly serves as a clear call to action for more local research to fill the existing gaps, validate these tools in diverse Indian populations, perform economic evaluations of therapies, and ultimately inform national policy and guidelines.
Given the undeniable and increasingly recognized overlap between MSLD and the metabolic conditions you expertly manage every single day, diabetes, obesity, dyslipidemia, hypertension, and considering the unique challenges and opportunities presented specifically in the Indian setting, from the distinct dietary patterns and genetic predispositions to the locally approved therapies like seraglutazar and the real-world infrastructure limitations. How can the insights you've gained today from this important consensus statement fundamentally reshape your approach? How can it prompt you to actively look for, identify, and proactively manage liver risk in every single patient with diabetes or metabolic syndrome who walks through your door, recognizing that their metabolic story is very often a liver story too, just waiting to be uncovered?